Good morning, everyone. We're just going to give a second to everybody to pop into the room. Welcome to our webinar. Okay, I just want to welcome everybody again as everybody shuffles in to Within's Continuing Education webinar. My name is Ashley Barkowiak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I would like to introduce you to Catherine Williams and Alicia Conter-Wilkins, who will be presenting on the topic of why ARFID deserves specialized virtual care. Alicia serves with us as a senior clinical lead. Alicia is a licensed marriage and family therapist, certified eating disorder specialist, and supervisor, and also is certified in mindfulness instructing. Alicia has 25 years of experience in behavioral health, working with children, adolescents, adults, and families. She has focused most of her career on working exclusively with eating disorders and has held various clinical leadership positions at all levels of care. She has been instrumental in launching eating disorder programs in both Florida and Virginia. She has specialized training in cognitive behavioral therapy, dialectal behavioral therapy, family-based treatment, and mindfulness. She has provided supervision and training for those pursuing state licensure in addition to IAEDP certifications. She is the past president of the Richmond IEDP chapter, served on the national board and as a chapter representative in 2021, and also volunteers with the Eating Disorder Coalition to support and advocacy efforts. Additionally, she has presented at local and national conferences. Alicia is passionate about ensuring that clients have access to care and that the most appropriate level of care, and believes that full recovery is possible. She also enjoys educating and family coaching and loved ones, and as well as supervising and mentoring the next generation of eating disorder professionals. I will also like to introduce you to Catherine Williams. Catherine Williams serves as a senior registered dietitian here at Within Health. Catherine also is a certified specialist in pediatric nutrition. She earned her Bachelor's of Science in Nutritional Science and completed her dietetic internship at Texas Christian University. She also has 10 years of experience in pediatric and adult clinical nutrition with specialties in eating disorders and gastrointestinal disease. She strives to provide individualized care and quality for her clients struggling with eating disorders. So I just want to welcome you both. I also have some general information to go over in regards to the CEU credits. Evaluations will be sent to your email that you use for registering for the presentation. Once the evaluation is complete, you will receive a link to download your CE certificate. Please utilize your CE Go dashboard for all things CE related. A video of the presentation will also be available after it is completed. You will not, however, get credit for just watching the video. You do need to attend live in order to receive that credit. To access the video post the presentation, that'll be available as well on your CE Go dashboard. If you have any technological issues and need to change devices during the presentation, you will, however, receive credit. I will provide both my email and Jamie Singletary's email in the chat in case anything does arise. And I will also provide CE Go's support number and their contact information in case you need to contact them directly on how to receive your CE information. Other than that, I will now pass things over to Alicia and Catherine, and please feel free to add any questions or concerns in the chat or message me directly during the presentation.
Thank you so much, Ashley, for such a warm introduction as well. Before we get started, we just want to thank all of you for attending this morning. For those of you attending from the Pacific Coast, very early good morning to all of you as well. Catherine and I have had the opportunity to present on ARFID together conjointly several times, and we were just reflecting in the green room before we came live about how much fun this presentation has been for us as we continue to learn more and more about ARFID, as we continue to read more of the literature that is coming out in regards to ARFID treatment, and getting to learn a little bit more from our clients about their lived experiences and what's working and what's not working. We've been able to continue to evolve this presentation as well, to the point that we've now extended it to 90 minutes from our prior 60 minutes. So let's go ahead and first set the table and talk about how we are going to spend our time today as well, and take a look at our objectives. So, also in just a few words, given some of the limited research regarding ARFID, especially with our adult population, it really takes all of us working together as a collaborative community to share what is working and what is not working, especially taking into account feedback from our clients to build the most effective and robust program. It also means learning from those with lived experiences. Some of the literature also emphasizes really the need to flex our creative muscles when it comes to developing ongoing interventions. So I'll quickly go through our objectives for today. And if you see me looking off to the side, I have another screen over here where the slides are much, much larger, and the print really stands out. So much easier to see. So today, learners will be able to state two strategies. We'll certainly go over more than just two strategies that can be used in the treatment of ARFID in a virtual setting. We'll explain the benefits of treating ARFID in a virtual setting, and we'll also specify treatment interventions, including but not limited to exposures, and how to implement these at higher levels of care in a virtual space. As many of you know, Within is an intentionally virtual program consisting of PHP and IOP levels of care. Let's talk about the diagnosis of ARFID. As we know, avoidant restrictive food intake disorder was introduced in the DSM-5 in 2013. However, the diagnosis is not really new, as it did replace the DSM-4 diagnosis of feeding disorders of early infancy or childhood. So what changed? The age of onset criterion was removed, and previously feeding disorders were limited to those under the age of 6. The weight loss criterion was also removed, really providing a diagnostic framework for those with feeding disorders without low weight. It also acknowledged psychosocial stressors and physiological consequences, such as nutritional deficiencies that we'll touch on a little bit later in the presentation, and also nutritional deficiencies due to failure to grow consistently due to limited safe foods. It also moved the diagnosis from a feeding disorder to an eating disorder, providing more treatment options for these clients. Let's talk a little bit about the epidemiology of ARFID. Peer-reviewed journals and manuals really have primarily focused on ARFID in children and adolescents, and we know that this is not a diagnosis that is just limited to children and adolescents. So for instance, in one setting, 67% of clients diagnosed with ARFID were male. We generally see a 2-to-1 male to female ratio. We also know there are comorbid psychiatric symptoms in addition to medical symptoms. We know, for instance, that children with autism are more likely to develop ARFID, and those with anxiety disorders are also at a higher risk of experiencing ARFID. Food avoidance or restriction may be due to fears related to things like contamination, abdominal pain, seeing another person vomit or choke out in public, or experiencing nausea or difficulty swallowing. Symptoms may also be correlated, for instance, with stress, anxiety, or trauma. Fears related to contamination of food may be due to messages that were received from peers, from family of origin. Restriction may also be a way to avoid experiencing an aversive event again. And restriction may also be a way to avoid unwanted tastes or textures in the food repertoire. This is something that an infographic that we newly added to the presentation. This was something that came out in early 2023. So again, we also do not want to lose sight of the fact that clients with ARFID are also adults. Currently, over 50% of clients with ARFID that we are treating here at Within Health are actually adults. So it's really important that we socialize some of the similarities and differences between the pediatric and adult populations. So again, as I mentioned, this is a study that came out earlier this year, and this is one of the largest studies to date looking at medical presentation in adult clients with ARFID versus adolescent clients with ARFID. In this study, most clients, as you can see in the middle column there, presented with fear of aversive consequences. That was really the predominant presentation. There were also concerns related to GI distress. Clients were more likely to have low blood pressure and food and drug allergies, as well as low potassium was something that both populations had in common. The predominant psychiatric comorbidity across both samples was anxiety followed by depression. And for adults, we also saw a lower mental health quality of life. And just something that I also want to point out is for the adult population, substance abuse related disorders were at about 31%. As we reviewed the DSM-5 criteria previously, I just want to point out as well that in the DSM-5, what was highlighted was marked interference with psychosocial functioning. That was a criterion for the diagnosis of ARFID. So that really reminds us to consider concerns around psychosocial interference, as there certainly are instances in which some of this criteria may be primary, as a client may already be meeting their nutritional and their energy needs and or are of normal weight as well. So clients eating a low volume of food may, for instance, be experiencing low mood, irritability, and difficulties maintaining concentration that might be causing difficulties in the work setting or some difficulties in the school setting. There may also be isolation due to fear of eating in public. There may be difficulties maintaining a job or being able to attend school. There may also be challenges managing friends and family relationships or difficulties establishing and maintaining relationships, again, due to the difficulties of managing eating situations. The family may also be providing accommodations to provide foods, for instance, from specific grocery stores or restaurants. And that really may be the family's way to manage their loved ones' emotions at this time as well. And for clients with ARFID, we also see a loss of self-esteem as they may not be able to engage as they once did previously with peers and loved ones and family members as well. Excuse me. Let's talk a little bit about the assessment of ARFID. When Catherine moves on to talking about medical and nutritional deficiencies, she will also highlight medical and nutritional assessment as well. So in my domain, I'm going to focus on the mental health assessment, and that will focus on providing a thorough biopsychosocial evaluation that will take into account the extent to which the avoidant or restrictive eating interferes with the client's activities of daily living, education, work, family, and social relationships, etc. In addition to evaluating other co-occurring disorders, such as anxiety. The assessment should also take into consideration the maintaining mechanisms for ARFID, and we'll talk about that momentarily. We may also look at symptomology and any behaviors that might be unintentionally reinforcing the client's symptoms. We want to look for those safety behaviors. We want to look for those accommodations that either the client is providing to themselves or that the family may be emphasizing unintentionally. The mental health assessment will also provide an assessment of the family or any loved ones who play an important role in the client's life. The family and loved ones are an important part of the team and will also play a valuable role in change. As I mentioned before, the family may be providing accommodations to provide foods from specific grocery stores or restaurants that interfere with variety. We want to look at how has the family been managing the restriction or avoidance in the home environment. Accommodations really may have become necessary to manage or avoid conflict in the family. Is positive reinforcement or negative reinforcement for that matter being used unintentionally, because the use of negative reinforcement may perpetuate the eating issues. For adults, we want to assess relationships and see if there's any link between their eating difficulties or any psychosocial stressors in their life. Has there been an illness in the family, for instance, or any bereavement in addition to other options? The multidisciplinary team may include specialists for more severe or medically complex ARFID presentations. It's often common to use a speech and language pathologist or an occupational therapist for many of the younger clients. In addition to clinical assessment, we want to supplement our evaluation with screening measures to contribute to our overall case conceptualization, to drive treatment planning, and to evaluate clinical outcomes as well. So if you look at the screen, we've got two categories outlined here. We have our structured interviews, and we also have the self-report measures. So for the structured interviews, the EDA-5, or the Eating Disorder Assessment for the DSM-5, is used for both adults and children and adolescents, and that's designed to assist in the assessment of a feeding or eating disorder. The youth version is used for ages 8 to 14, and the adult version is used for ages 15 and up. This assessment aligns with the DSM-5 diagnostic criteria for ARFID in adults, in children, and adolescents. The structured clinical interview for the DSM-5 is used primarily to diagnose ARFID in adults. And the PICA ARFID rumination disorder interview, otherwise known as the PARTY, is used to rule out other eating disorders and determine the presence of ARFID. This is the assessment primarily used in the treatment modality CBT-AR. The PARTY has 4 versions. There's a parent caregiver version for ages 2 to 3. There's one for ages 4 and up. There's one for ages 8 to 13, and adolescents, of course, included in that population. And then there's one for ages 14 and up that also includes the adult population. This assessment not only looks at ARFID, but also considers the severity and looks to rule out other eating disorders. So this is an assessment that is highly recommended. It's lengthy. It takes about 45 minutes to administer. It is, however, very in-depth. It's meant to complement the EDE and is meant to drive treatment planning. If you look over at the self-report measures, for instance, we have the 9-item avoidant restrictive food intake disorder screen, otherwise known as the NIAS. That is an outcome measure that we use here at Within Health. This very simply contains 9 items, contains a severity assessment that looks at eating restrictions related to picky eating, poor appetite, and fear of aversive consequences. And lastly, the state trait anxiety inventory also looks at the anxiety predisposition, as we know that anxiety is common in ARFID populations. Let's take a look at some of the assessment maintaining factors. So again, going back to some of the assessments that we just looked at on the previous slide, the PARTY and other assessments were designed to assist the multidisciplinary team in really conceptualizing ARFID symptoms in this 3-dimensional space. It can be helpful to conceptualize the case with the client and with the family and gathering their input when doing a structured clinical interview, a self-report measure, or just your overall standard clinical assessment. Maintaining factors promote avoidance and/or restriction and may strengthen responses without intervention over time. We know that ARFID is an eating disorder associated with avoidance and restriction, and where there is a lack of interest that may be reinforced by restriction over time, resulting in limited intake for the client. We know that limited volume can lead to more health issues over time versus that of limited variety. For instance, selective eating and limited variety may be maintained by disgust or disgust sensitivity. There may be negative predictions or thoughts around food that also reinforce the eating difficulties. And lastly, fear of aversive consequences, such as physical problems that include but are not limited to physical or GI pain, abdominal pain, anxiety around a severe allergic reaction, worries around choking, vomiting, fear of contamination. The fear of physical consequences reinforces the restriction, as does the fact that when there has been a decrease in the negative consequences, that also reinforces the food avoidance for our clients. So it really, if you will, perpetuates the cycle. Treatment can be individualized to target the client's maintaining factor. We also want to keep in mind that there's often an overlap of these presentations, and prioritization of the main driver assists with treatment planning. The CBTAR manual also outlines the various interventions that are dependent on the maintaining driver.
Next, we'll dive into the nutrition assessment. So the nutrition assessment is really an opportunity to get some more information regarding the ARFID presentation and how it is physically affecting the client. As you can see here, there are some pretty typical things that we assess for in all of our patients, and then some things that are pretty unique to our ARFID population. So just to highlight a few things that are more typical, but we want to pay attention to. Number one, under anthropometrics, I always like to try to get growth charts whenever possible, just to see a nice history of how this client has been trending ever since infancy, if possible. Assessing any GI issues that might be influencing intake. So, like Alicia just went through, I really like to assess how some of those GI issues might be influencing those maintaining factors. Of course, assessing hydration status, vitamin and mineral deficiencies through laboratory values, and we'll go a little bit more into nutrition-focused physical exam today. And then lastly, malnutrition criteria assessment. So assessing how their weight loss has been. Do they have a lower BMI? Are they meeting their nutritional needs? The things that are a little bit more unique that I go more in depth with for the ARFID population is history of the eating patterns. So I always like to assess for any picky eating or failure to thrive in that infant toddler stage, or any reflux as a baby, to really get a better picture of when some of these eating concerns may have began, and maybe also to how the family may have reacted to some of these eating concerns early on, because we know that some of those relationships around food early on can really have an impact later on in life. And then the other thing that's pretty unique to our ARFID population is our hierarchy of foods, which we'll spend some more time going through today. But our hierarchy of foods is really an opportunity to really organize how we are going to begin with our meal planning and where we might hopefully go with some of our exposures. So just to go a little bit more in depth with some common nutrient deficiencies. So one thing I like to highlight with our ARFID population is there are times when someone may not meet criteria for malnutrition, but may have some of these common nutrient deficiencies because of the repertoire of their intakes. So just wanted to highlight some of those common nutrient deficiencies because on, like I said on the previous slide with the laboratory values, these are not always nutrients that are routinely assessed. So calcium, folate, iron, vitamin A, vitamin D, vitamin K, zinc, and vitamin C are the most common ones we tend to see. And I also listed here some of the common foods that we might find these nutrients in. So you'll see pretty repetitively here, leafy green vegetables, meats, fish, seafood, dairy products. So those are kind of the most common ones. And also just want to highlight, calcium, vitamin D, iron. Those are nutrients that we're pretty routinely checking through the medical provider, but folate, vitamin A, vitamin K, zinc, vitamin C, not always things that we are always assessing for even though they are common nutrient deficiencies among this population. So that's where our nutrition focused physical exam comes into play. So of course, when we work virtually, a lot of times we're only seeing our patients waist up, but there are quite a few assessments we can do to assess for vitamin and mineral deficiencies without being able to see all of the clients. So I challenge a lot of people just to kind of go through some of these assessments. So looking at hands, we can assess for iron deficiency, looking for those spoon-shaped nails, zinc deficiency, looking for some of those like defined lines. Visually looking at their face, we can see if we have those like beefy red gums, that's more of that vitamin C deficiency. And then looking for like those cracks and chelosis around the mouth, which is representative of potentially a folate deficiency. And then in the middle, you'll see some of that like scaly, dry skin for essential fatty acid deficiency. So our essential fatty acids help us absorb our fat soluble vitamins. So our vitamin A, D, E, and K. So if we're not sufficient in our essential fatty acids, chances are we're probably not absorbing our fat soluble vitamins well either. So assessing for these things and then really working with our medical provider to maybe do some more tests to verify some of these assessments that we're seeing. And then our hierarchy of foods. So like I said earlier, this is really our tool to organize opportunities for exposure, and then also provides a lot of context to when and why some certain foods became unsafe. There are many, many, many hierarchy of food tools out there. Some people like to do more of like a red, yellow, green, meaning like our green foods are safe foods that we're willing to eat pretty frequently. Our yellow foods are those ones that we might be willing to try, but aren't ones that we tend to do all the time. And then our red foods are foods that we can't imagine doing ever. There is a free one available on the CBT AR workbook that you can access online. At Within Health, we tend to use the food preference list, which is in the Conquering Picky Eating workbook. We like this one just because it provides a very extensive, descriptive list of foods to provide a lot of prompts for the client to really think of like all the different foods and food categories that they might be willing to eat, currently eat now, and provides a lot of context to really figure out like when these foods became unsafe and how willing are the client to incorporate these foods again. Like I said, sometimes these hierarchy of foods can be pretty extensive. So, um, there are times when I like to give the hierarchy of foods to a client to do on their own and then bring back to session. If that's too overwhelming for the client, sometimes we do it together in session. And then we also have care partners who are always willing to do the hierarchy of foods with the clients as well, and then bring it back to the dietitian to assess together. So lots of options when it comes to the hierarchy of foods. And I think it really comes down to like what method is going to be easiest for the client to complete and build off of. And just wanted to highlight some goals for treatment. So of course, first and foremost, we want to support our clients in achieving and in maintaining a healthy weight, and along with that, correct any of those nutritional deficiencies that we have found early on. Really support our clients in expanding their repertoire, so really expanding upon the food groups that they're willing to eat, becoming more comfortable in social situations that involve food. So maybe this could be going out to dinner with friends that maybe we haven't done, or going on a date. And then lastly, engaging in eating experiences that are important to the client's overall well-being. So really challenging and supporting our clients in engaging in some of those eating experiences that maybe have really held them back from some situations or opportunities in the past.
When it comes to therapeutic interventions, providers, as we mentioned before, are really having to adapt existing treatments, taking into account what we know about ARFID, what we know about co-occurring disorders, in order to develop some creative interventions. An assessment may be needed by an occupational therapist or speech and language pathologist to determine appropriateness for exposure therapy. So this may be warranted in medically complex cases, especially if there's oral sensory motor concerns, difficulties with texture progression, swallowing, etc. An OT may also be warranted when there's difficulty processing sensory input, difficulties with ADLs, for instance, concerns around self-regulation and distress tolerance. Looking at a few of the other therapeutic interventions, there's certainly some that I just want to make sure to highlight here as well. DBT and CBT, with both of those modalities, the goal is to help our clients better understand their emotions, what their emotions are telling them to do. The goal really is to help us challenge those unhelpful thoughts and learn more adaptive skills in the treatment space. Socialization, we want to provide increased opportunities for socialization, as Catherine mentioned. Give our clients the opportunities to try out some of the new adaptive skills that they are using. That is certainly going to strengthen the use of those interventions and behaviors. For family interventions, we want to work with the family to reduce family accommodations that may unintentionally be reinforcing the behavior, the avoidance, or the restriction. Behavioral interventions may also include the use of a reward system to decrease some of the maladaptive behaviors and increase the use of the adaptive behaviors. We also want to provide exposures or interoceptive exposures for those with the ARFID subtype of lack of interest, and behavioral exposures for fear of aversive consequences. Anxiety management may include mindfulness, relaxation techniques, movement, and biofeedback. Catherine is going to touch a little bit on movement later today. I was at a small group on Sunday evening with some friends, and one of the friends was talking about some of the things he does before he actually has to give a presentation, and he called them big movements. And I was thinking that is so perfect. That's such a perfect intervention for our clients before they engage in exposure. So a big movement would be standing up, swinging your arms, going from side to side, getting out some of that anxiety prior to engaging in the exposure as well. DBT might also be utilizing a pros and a cons list to look at the benefits and the risks of changing the behavior and learning more of the adaptive tools and ways to implement them. And lastly, we may also use motivational interviewing when we see that the readiness to change is on the lower side.
So nutrition goals for ARFID treatment. I always love this image from the Ellen Satter Institute because I feel like it provides a really good roadmap for our treatment with our ARFID clients. So first and foremost, starting at the bottom of the pyramid here, we want to make sure that we're helping our clients have enough food to really meet their needs. And then moving into, do they have some reliable foods that maybe they can get when they have to go to class or are on a vacation or have a doctor's appointment, anything like that. And then we might move into, hey, food can be a little bit more enjoyable. What are some good tasting foods? And then lastly, looking at some of those instrumental foods. So one of the initial things we do, of course, is assess for micronutrient deficiencies. So let's say we've been supplementing iron for a while. This might be, maybe towards the end working on including more iron-rich foods that maybe didn't fall into some of these categories sooner in treatment to really expand the client's ability to increase variety amongst their intake. And where do we begin? So like I said, we really start at the bottom here, just trying to prioritize enough energy more than anything. And I love this image of the plate of chicken nuggets here because I've totally recommended this before. So we really just want to increase the portion amount of safe foods to meet the client's needs more than anything at first. Increase intervals of eating occasions. So if I have someone that typically doesn't eat until 3 o'clock every day, I might try to get them in programming for morning snack or lunch, just trying to provide more opportunities for them to eat in the day with support. Maybe we use some nutritional supplements just to make sure that we're meeting the needs and filling the gaps to begin with. And then of course, providing our clients with enough hydration. And if that's something that they struggle with, in these cases too, we might be thinking of different flavored beverages that they enjoy, or maybe foods that they're willing to eat that include more fluid. So things like applesauce or yogurts, fruits that maybe they enjoy that have more fluid in them, just trying to get enough fluid in. And then lastly, like I said, vitamin and mineral supplements based on some of these initial assessments that we've done. And then we move into more of the fun part. So what's missing on my plate? So this is really more of our opportunity to assess the hierarchy of foods in relation to the client's estimated needs. So this is our opportunity to really look at where we're at and where we ultimately want to go in supporting the client and meeting their needs. I always love this image of what we call here at within health our Thrive plate. So this is how we explain to our clients meeting about 30% of our plate grains, 30% protein, about a third of our plate fruits or vegetables, and then depending on the client's needs, adding a beverage or a dairy component, and then lastly, making sure that we have a visible fat source. So really taking a look at this plate in comparison to where they might be starting at, and really filling in the gaps from there. I always like to highlight this last bullet that we have here. What is going to be most enriching to my client's life outside of treatment? So, yes, we want to really support our clients in having as many of these different food groups on our plate. And maybe they really want to go to college soon, or maybe they want to go to sleepaway camp, or even just eat maybe the school lunch. What is going to be exposures that are not only meeting our clients' needs first and foremost, but also going to be really supportive in life outside of the eating disorder. And next, we'll dive into a little bit more of the exposures and exposure therapy. So, exposure therapy is a evidence-based treatment modality to treat phobias, fears, and anxieties, which breaks the cycle of fear and gradually exposes the client to fear in a controlled, monitored manner. This can involve sitting with the food all the way up to eating the food, which we'll dive into a little bit more soon. And then also using the SUD scale to assess anxiety throughout the exposure.
The other thing that we can do here therapeutically or behaviorally is once we have obtained the SUDS score, and if we see that the client's anxiety is really high, as I mentioned before, we could do some of the big movements. We could practice some mindfulness. We could do a progressive muscle relaxation as well prior to engaging in the exposure. We could also teach our clients how to implement some distraction techniques. We could sing together. We could provide some soft music in the background. And again, these are all going to be strategies that work well with children and adolescents in addition to adults, and also techniques that we can provide to families and carers and loved ones as well who will be involved in the treatment process.
So just to highlight a little bit more of what these exposures can really look like. So, as you can see here, it can really go from just sitting in the same room as a food, or all the way up to eating an entire piece of the food. So, just wanted to kind of like open up the opportunity that an exposure doesn't necessarily mean having to just eat the food. It can be licking the food. I always like how it's written, kiss the food and throw it away. Just tolerating the food on your plate is a huge feat. And then you can see over on the right here, this fear thermometer. So really taking the temperature of that anxiety throughout the exposure. And like Alicia said, taking that temperature and then supporting the client in ways to really get through the exposure and bring some of that fear down.
The other thing that we can do here as well, depending on how high the anxiety is if it's really high, we could even start with something simple as looking at a picture of a non-preferred food. So we could even start with a picture of the food before we move into some of these other strategies as well. And depending on if the goal is to increase volume or increase variety, we may also start with adding in foods that the client used to enjoy before we get to some of those non-preferred foods as well.
Just wanted to highlight a few more ways that we can expose our clients to new foods. So number one, food chaining. So let's say I have a client that will only eat McDonald's McDonald's French fries. I might go from a McDonald's French fry to a Wendy's French fry, and then making our own French fries at home, and then cutting up potatoes and making our own French fries, all the way until we get to like eating a full baked potato. Um, this can kind of classically be done also with like a chicken nugget, going from a chicken nugget to having like a piece of grilled chicken. Also decreasing quantity of preferred foods on plate, and then fading in some more of those novel foods. So instead of having just the novel food on your plate, we have some familiar, comfortable foods on the plate along with those novel foods. Adding spices, sprinkles, condiments, just to really provide some different flavors and presentations to these new foods. And then really just switching up the presentation, especially with some of our younger populations. You know, this could be different plates, this could be different utensils, using food cutters to make different shapes, just to try to um, provide some more comfortability when it comes to doing some of these exposures and including new foods.
We know we have a lot of outpatient providers in our audience today, so thank you all for being here. CBT-AR is the first manualized treatment for ARFID, and that was developed by Jennifer Thomas and Cameron Eddy out of Harvard University. This is designed, again, to be utilized on an outpatient basis. There are two versions of this. There's an individual version. There is also a family-supported version. So the individual version is really designed to be used for ages 16 and up who are of normal weight or slightly overweight. The family version may be used for those 16 and 17-year-olds, however, who do need to weight restore and really need the family support when it comes to meal support and coaching in order to weight restore. In a study that evaluated CBT-AR for adults, what they found was at the end of treatment that 18 new foods were added to the client's repertoire. And 47% of these clients no longer met criteria for ARFID. There are also 4 modules. As you can see, modules 1 and 2 really focus and hone in on psychoeducation as well. If you look at my last bullet, as Catherine had mentioned before about the free workbook, I've provided the link to the free workbook. This is a client and family workbook that does embrace the CBT-AR model. There are a lot of infographics in there that I really like to use when I'm providing psychoeducation for clients, families, and any of their supporters as well. They're certainly very user-friendly. The model also emphasizes that the therapists really take a stance when it comes to treatment that is non-judgmental, non-blaming, and empathic as well. And when we see positive change utilizing this model in the first 4 weeks of treatment, that predicts positive outcomes at the end of treatment as well. Psychoeducation, whether we're using the CBT-AR model or we're using other interventions as well, psychoeducation is a hallmark when it comes to ARFID treatment. This is an opportunity where we can come together to discuss our conceptualizations of the ARFID with the client. We can provide psychoeducation on ARFID in general, some of the maintaining mechanisms or drivers. We can also assess the family dynamics and the responses to some of the food behaviors. And we can also discuss treatment approaches and determine together in which direction we are going to go when it comes to treatment. We also want to help clients and loved ones understand that they have underlying biological traits in which their eating practices make sense. So we want to normalize this for them. They avoid food, for instance, to avoid an aversive response or gastrointestinal pain. We all would probably do that, right? We don't want to assume that clients or loved ones know about ARFID due to it being a much newer diagnosis as well. And again, use some of the infographics from that workbook. And I saw that somebody had put in the chat inquiring about the link. We'll make sure to get that to you. Psychoeducation does support treatment engagement as well as assists with increasing rapport with the client. Family accommodations can maintain the ARFID by promoting avoidance, thus reinforcing some of the client's negative beliefs about their food issues. Accommodations may also serve to decrease the client's motivation for overall treatment, and parental pressure also decreases intake and may increase food aversions as well. So really working with the client and the family on psychoeducation, talking about positive reinforcement and figuring out what are some things that we can implement in the home environment. We also want to educate on comorbidities and determine if there's any treatment modifications that need to be made depending on the diagnosis. So when there is a comorbidity of autism, for instance, we really want to look at how we can make treatment most effective for these clients. Self-monitoring also allows us to track how the client is doing outside of the structured sessions. A lot of the work is being done outside of the individual therapy, outside of the nutrition sessions, outside of the group therapy as well. And we can also look at implementing a positive reinforcement system with monetary rewards, for instance. We may want to start very small, where we're providing an award after each exposure, after each meal, and then move up to more of an intermittent reinforcement system over time as well. And that's certainly going to look different based on the developmental stage of the client. So support for parents and loved ones and supporters, we really want to bring as much support into the client's treatment environment as we can, starting with the assessment. We want to look at what are some food rules that are being communicated in the home environment. We want to consider habits, practices in the family, practices among friends for our adult clients as well. There are certainly many benefits to being virtual, one being that parents and loved ones do play a significant role in daily exposures and management and coaching. And if we can involve a supporter for our adult clients as well, we can certainly see some more positive and successful outcomes. We want to work to assist the parents with at-home practice, loved ones as well. For instance, we can teach parents creative ways to engage in exposures at home outside of the programming time. So for instance, in one study, parents were encouraged to call these food experiments instead of calling them exposures. So again, we want to flex that creative muscle, as I talked about very early on today, and figure out ways that are going to work for clients. We want to consider each exposure with curiosity. We talked about the implementation of a reward system that may work for adults as well. I know I respond to some rewards too. A cup of coffee will work for me any day. Non-food rewards can be provided for successful exposures. So for our children and adolescents, think about, what do kids want these days? They want their electronic time. They want their television time. And for older children and adolescents, a point store might work where they can cash in their points at the end of the week and get a token as a result. And then also there's going to be just some natural reinforcement that we see over time as there are more successes. less pain, more use of adaptive behaviors with more of a positive response, again, that's just going to be some natural reinforcement. So we should see some of those behaviors start to continue. We also want to assist parents and loved ones with really creating a positive mealtime environment that's free of distractions, no electronics at dinner, for instance. That will help to support decreasing some of those maladaptive behaviors and increasing those positive behaviors. And then strategies in some studies that were perceived as, I'll say, quote unquote, forced were indicated as not helpful. But again, it goes back to looking at the family dynamics and our parents at a point of, or caregivers or loved ones at a point of being burned out, and they too need their own distress tolerance skills as well. So the support for parents and loved ones and supporters also involves teaching them some coping skills and arming them with their own distress tolerance skills. You know, we can also utilize emotion-focused family therapy. We can teach parents a validation sequence that can also be used with their loved ones as well. We certainly don't want clients to feel as though exposures are being forced on them. We want to include some more validation in that practice and empathy, and we want to remove possibly some of that judgment that our clients are feeling. As I mentioned before, we can also adapt treatment for those with co-occurring disorders, such as those with neurodiversity, or really those needing to really target weight restoration as a primary focus. Adaptations for some clients may include more frequent breaks in their schedule throughout the day, shorter sessions for children and adolescents. You know, instead of providing a 5-step direction, maybe we provide a 2-step direction. So we want to break these things down in a way that is manageable for our clients as well. Visual cues work really well with some populations, you know, also providing a visual of the SUDS infographic during exposures. For younger clients, we may want to print out pictures of emojis and laminate those and use those during exposures so we can really assess what emotions are coming up for them in the moment. In one of our groups, for instance, we use animal metaphors as a way to help our clients identify what type of support they need that day or how much involvement from the staff they would like at mealtime and in our process group, for instance. So as I mentioned, pictures, animals, emojis might be a helpful way for clients to communicate their needs to us. DBT adaptations also include modules around building a sensory toolkit for times of distress or when clients are overloaded from a sensory perspective. We may see some clients with a diagnosis of ARFID who do have some sensory sensitivities and characteristics as well. And just one resource to point out to all of you is that the National Institute for Health and Care Excellence does offer some guidelines for working with autistic individuals and those with eating disorders as well. So I found a wealth of information in that resource. And I would be remiss if I did not touch on treatment at higher levels of care for ARFID. That is what we do here at Within. We provide partial hospitalization and intensive outpatient. We see that intensive treatment is effective in reducing ARFID symptoms in adolescents, and higher levels of care are very often needed for clients that are needing to weight restore or that have some nutritional deficiencies, or when medical management is needed. What we saw in one study is that 79.2% of clients remained out of the hospital at a 2-year follow-up following treatment for ARFID at a higher level of care as well. Higher levels of care also offer more group opportunities, not only for clients, but support for parents and loved ones, such as separate skills groups, weekend planning sessions, family meals, and it also affords our clients and their loved ones access to their multidisciplinary team in one space. All right, well, let's talk about the pros of virtual treatment. One of the hallmarks here at Within is that we do provide effective treatment at home, and we can provide effective treatment in the home setting for ARFID. And that includes parents and supporters as well. Again, taking into account that they are a part of the treatment team as well. Food and other supplies are then more readily available in the home so that exposures and problem solving can take place in the moment versus when you're in more of that contained clinic setting. It's an opportunity for the team also to observe and really assess if any accommodations are taking place in the home environment that might be reinforcing some of the avoidance and some of the restriction again, so that we have an opportunity to intervene in the moment and affect change in the moment. In virtual treatment also will be a benefit for those clients who may be immunocompromised as a result of the restriction and the avoidance. So it limits them having to go into a clinic where maybe they are exposed to the colds and the flu, certainly that we see this time of year as well. So there's so many benefits of providing virtual treatment as well. Some of the cons that we saw for virtual treatment are there may be things that are unintentionally reinforced in the home environment. A client may not complete an exposure, for instance, but their dog runs over to them and the dog is a reinforcer for them. You know, they're very close to their dog, for instance. So there may be some things that reinforce the behaviors that we are trying to change unintentionally in the home environment. As Catherine mentioned before, working virtually, we only get to see this to this. So if I have a client that I am doing an exposure with, and maybe they've told me on a SUDS their anxiety is at a 3, maybe what I don't see is that their leg is bouncing up and down at this moment. So they are exhibiting anxiety, but from here up, it's something that we don't see. Clients also become distracted sometimes by their image on the screen, so that can create some engagement difficulties as well. And then, of course, some of the privacy concerns, certainly with doing this work in the home environment as well. So how are we doing? This slide for Catherine and myself and the whole Within team, really is a checks and balance for us of the work that we're doing here in this virtual space. We are fostering a community of support for our clients with ARFID. We've talked a little bit about CBT-AR and DBT and how we can make some of those adaptations depending on some of the co-occurring disorders that we're seeing. We have an ARFID process group, as I mentioned, and that is led by our wonderful primary therapist, Brittany Ashmore. She's really made that an affirming space for our clients with ARFID. And it's really been a space for them to build community and share about their experiences. We also have provided a parent and loved one support group and are working towards providing parent coaching as well, utilizing our current parent coaching model with some adaptations as well for ARFID. And that is a space to provide psychoeducation, answer questions, address concerns, and provide support. We also engage care partners, and they play a very important role, and they provide experiential opportunities to our clients with ARFID, and that might include the task of creating that sensory and calming environment that we've talked about in the home setting to support some of the exposure opportunities as well.
Individualized nutrition support. So it's been really fun to see how our nutrition team has really grown and educated ourselves and tailored some of our programming and supports to meet our ARFID clients where they're at. So we have ARFID specific meal support with trained care partners. So this is meal support with clients that just have a ARFID diagnosis. And then during those meals, like Alicia was saying, we use those icons of the animal check-ins so that the care partner and the client can really connect on what they really are needing for support in that meal. They use the SUD scale throughout the meal as well to really assess for anxiety and provide some supports throughout the meal as well. One-on-one exposures with the dietitian at least twice a week. So we start doing those when deemed appropriate and nutritionally sound enough to start including some of those exposures. We have some amazing food specialists on our team, and they work one-on-one with the client to decide what foods we should be sending to them based on their food preferences, challenges, exposures, one-on-one cooking exposures with chefs. So us as the dietitians, we're doing some more of those one-to-one exposures with tasting the food. And we have our food specialists who are also some trained chefs, and they're doing one-on-one cooking exposures with the client and really getting them more comfortable touching, using food, being in the kitchen. I have some clients that are terrified of going in the kitchen, and it's really amazing to see their growth and comfortability in the kitchen through these one-on-one exposures. And then lastly, we have meal logs that the dietitians are able to review and see exposures, eating experiences outside of programming, and provide some feedback in the moment and also support in the moment whenever they need it. I know Alicia mentioned this towards the beginning, but very excited to share our movement protocol. So no matter the diagnosis, everyone in our program is having a one-on-one assessment with a movement specialist to evaluate what their current movement regimen may be, and then really help support and provide some goals based on what their movement goals may be. We also have quite a few movement groups in our programming, such as breath and stretch, chair yoga, flow yoga, Pilates, breath work, meditation, some movement psychoeducation groups to really support and develop movement as a part of their work and programming. So you can see we have different movement levels, and that helps us as the clinician support the client in meeting, what their body is really needing at that time and what groups are most appropriate to foster where they're at in their journey. So courage is very much that level where we are really supporting the client in reducing stress on the body. We might do some stretching, but really giving the body that opportunity to heal. Determination level is when we might be including some more gentle movements, such as mindful walks, yoga. Perseverance may be when we might be doing some aerobic movements, but also, maybe doing some flow yoga or vinyasa yoga classes. And then empower is more customized to our clients that might also be athletes or have different movement goals, to really tailor to their needs in their recovered life. Creating a sensory environment. So I know Alicia went through some of these already, but just wanted to kind of run through again, what are some things that we might be supporting our clients in those ARFID meals, some things that we might be doing in our one-on-one exposures, and then also educating families on to really best support our clients during some of these exposures and through their entire treatment process. So sitting down for meals, trying to get some of those distractions out of the way during mealtime. Maybe we turn on some enjoyable, soothing music. I always love like having Christmas music on during meals during this time of year. Coping tools available. So maybe we'll have our ice pack available, or a heating pad, or a coloring book, have those things available to really provide the tools that we might need. And then I always love the last one, don't yuck my yum. So really thinking about like, what are some of the things that we might be discussing at meal times? How are we describing foods at meal times that might be helpful or not helpful in these situations?
A little bit about, excuse me, some of the support we've implemented here for our clinical team. We have a team of ARFID professionals, and we come together on a regular basis. And it's really a chance for us to continue to build out an effective ARFID program in a virtual space. It allows us to look at some of the new literature that's coming out, but also not only an opportunity to take into account some of the peer-reviewed journals, but also some of the feedback that we get from clients and those with lived experiences. There are also many web pages and social media pages out there also detailing clients' lived experiences with ARFID, what's worked, what hasn't worked. We implemented an ARFID case consultation group, and this is a time for our multidisciplinary team to come together, look at case conceptualization, get some support around determining what are some of the maintaining mechanisms on this case, and to look at treatment planning overall. We want to ensure that we are using our time in our staff meetings, our treatment team meetings, to discuss goals for the next week. That might be planning out the exposures over the next week and to process what was helpful this last week for our client. And as we mentioned over and over, our clients are so valuable, not only to our team, but also to our clients. And they have really the primary responsibility of supporting clients at our ARFID specific meal table. And that is a space carved out for our clients with ARFID to have meals and to build a community. So let's talk a little bit about next steps. We are working to build a robust exposure log into our app that our clients and our team members have access to. So clients can also have a hand in accountability monitoring. We want to look at additional movement groups to assist clients with ARFID in decreasing their anxiety and or their distress, especially prior to going into a meal or going into an exposure. We want to continue to expand our offerings for our parents, our loved ones, our supporters, and continue to provide those increased coaching opportunities and psychoeducation opportunities for them, especially around behavioral strategies. We want to continue to look at offering more ARFID-specific skills groups. And lastly, we want to explore some other ways to increase exposure opportunities. As Catherine mentioned, we're already doing some culinary one-on-one, but how can we look at incorporating food in other ways, such as food-based art and food play? We want to really teach our clients first and foremost that food can be fun as well, and we can learn to rebuild their food repertoire so that they can move forward with having a rich and meaningful life as well.
All right, so now we'll dive into just a few case studies. So just some representations of some clients that we have seen here at Within Health, and some of the interventions that we have used as a team to support these clients. So the first one here, we have a 29-year-old cisgender male who hasn't been able to eat around people since he was a child after experiencing a choking incident. This led to fear of choking and fear of eating in front of people. For years, this person would eat by himself at home, but then in September of 2022, he choked while he was at home, and then because of this experience, lost a significant amount of weight over an 8-month period. He was primarily consuming fluids and eating very small amounts of food. This client was admitted to our program at PHP level of care, 7 days a week. And first and foremost, want to highlight, this person had lost 40 pounds over 8 months. So really, more than anything, initially in treatment, the dietitian really supported this client in weight restoring. And then once they were able to weight restore some, the therapist and the dietitian really kind of separated their roles, and the therapist really focused her exposure and treatment on the fear of choking. And then the dietitian really focused her attention on exposure to different consistencies of food, because this client initially came to us eating a lot of fluids. This client made a lot of progress during his time with us. And I think one of the hallmark things was he was able to go out to dinner with his family and eat dinner with his girlfriend that he hadn't ever eaten a meal with. So really, really impressive work that this client did, and loved the collaboration between the therapist and the dietitian to kind of divide and tackle, to really support this client in making a really impactful difference for him. Next one is a 34-year-old female who presented to Within Health for PHP after spending 2 weeks at an inpatient hospital and then 8 weeks at residential. So before this, the client was experiencing severe abdominal pain, which impacted this client's ability to eat many foods in adequate portions. When this client admitted to inpatient, they were at 65% of their ideal body weight. And through the work of inpatient and residential, was able to weight restore to 95% of ideal body weight. But when this client presented to us, they were meeting more than 50% of their intake from supplements. And then I think the other key thing is this person was very uncomfortable with being in the kitchen and cooking food, didn't have a blender to really make some of these nutritionally dense supplements that have been really supporting this client in maintaining their progress at that inpatient and residential level. This client has done really amazing work with our food specialist and has worked up, so started just um doing some exploration around the kitchen, using like the toaster and then using the toaster oven and then using the stove, and have worked their way up to using the oven. With me, we've had the opportunity to do a lot of food exposures, and then this client is now fully eating food to meet their needs, so no longer needing supplements. And then on the therapist side of things, they're really working through a lot of the anxiety and depression that has come up throughout this entire process as well. So another case of how the team has kind of worked together in ways to support this client, and really impressed with the work that this client has done, and continues to do.
And lastly, we'll move on to case study 3. This is a client who is a 20-year-old cisgender female referred by her primary care provider and outpatient dietitian to Within Health after not being able to weight restore. Client has a history of chronic GI issues, which over time led to avoidance of certain foods as the client's anxiety increased. Ongoing GI testing did not yield any specific medical diagnoses that may have contributed to the GI issues. Client reported a desire to eat more and gain weight, but had learned to avoid food to limit the GI discomfort. Food avoidance had also begun to impact the client's mental health. Client was no longer attending school or doing things she used to enjoy, such as volunteering with children. So first and foremost, weight restoration was our primary target with this client. So we initially worked to increase volume of food intake utilizing preferred foods. Exposures to add foods back in eventually that the client used to enjoy. And then we really moved on to some of those non-preferred foods. Our care partners worked with this client on food exposures. We also worked with this client on coping skills with the addition of some grounding skills, the utilization of mindfulness. We also worked on relaxation techniques to engage the client's parasympathetic nervous system prior to exposures. And we also used progressive muscle relaxation and deep breathing. Cognitive behavioral therapy assisted this client with connecting the worry thoughts and fears with the restriction and the avoidance as well. We also engaged this client in our cognitive behavioral therapy group, our ARFID process group, and we have a somatic-based group called Working Your Nerves that this client also participated in. So that was the client's treatment plan, and the client eventually graduated successfully from our program.
And here we have all of our list of resources. And then lastly, here is mine and Alicia's email. If you have any additional questions, please, please, please feel free to reach out to Alicia or myself so we can discuss more.
I dropped the link to the workbook in the chat as well. And again, we just, on behalf of Catherine, myself, and Ashley, and Within, we just want to thank all of you for coming out today. We know it's a busy time of year. It was so nice to see our Within colleagues in the participant list, as well as I saw some of my former colleagues out there too. So thank you all for joining us today. We do have about 5 minutes left, so if anyone has any questions, we are here.
Thank you, Alicia and Catherine. That was so insightful. We did have some questions roll through that I'll get us started with. The first one was, What gaps have you found with ARFID care, and how is Within Health closing these gaps for more well-rounded care? I know you touched on it a little bit in your presentation, but if you wanted to expand.
I think for gaps, excuse me, I think some I've seen is just there's some knowledge gaps out there too. Because we're a virtual program, we need to involve the primary care providers as well to monitor and manage clients medically. So those are some of the gaps that I've seen first and foremost. Um, Gaps have also been, ensuring that the parents are involved or that there is a supporter involved, especially because we do rely on them so much to be a part of, this treatment team environment. And there is a lot that we are asking them to engage with in the home environment and to participate in the exposures as well. Catherine, anything you would add?
I think one of the biggest things that comes to mind on the nutrition side of things that maybe we don't have as much opportunity in some other settings is really the opportunity to go along with the client with a lot of these experiential opportunities. There'll be times where myself or a food specialist or a care partner might be on the phone or on a FaceTime with a client as they're going to different experiences or going to the grocery store. So I think that's one way that we might previously not had an opportunity to really be a part of.
Wonderful. Thank you both.
Yeah, that's a great point, Catherine. I know one of the, we were talking about the food experiments. I know there were a couple experiential opportunities I had read about that some providers are doing. One was gardening with a client. We can certainly do that virtually as well, and it looks a little bit different too when you're doing that in person.
Wonderful. Thank you. Another question that rolled through was, have you found any benefits in incorporating ARFID patients into care with other eating disorder patients?
I think, and we have done some of that as well. It's probably been within the last 6 months that we have really put a lot of time into and attention into building this ARFID track out, if you will. I think just a sense of community that our clients get from being together as well, and knowing that there are some commonalities, because when we look at the co-occurring anxiety, for instance, or depression, even if the eating disorder diagnosis is different, there may be some concurrent overlapping comorbidities among our clients as well.
And on the meal side and nutrition side of things, we always give our clients a choice if they want to be a part of the ARFID meals. So if they're feeling more connected in our community meals, we of course support them in that. And if they feel more connected in the ARFID meals, we want to support them in that as well. So there's always a choice there. And I always ask our clients to, each week, hey, how are things going? Is this helpful? Is this something that's supportive? Or do we want to try something different that might be more supportive right now for where you're at?
Mhm. Mhm. Yeah, we rely on a lot of, client feedback with this too, as we were talking about those lived experiences. And I will say that is some of how a lot of what we are doing here evolved as well. There's nothing like learning from our clients.
Wonderful. Thank you both again. I just want to extend another thank you to Catherine and Alicia for sharing with us today their knowledge and experience with ARFID. I also want to extend a thank you to all of you for sharing in this space with us and for also joining us throughout the 2023 webinar series and for partaking in our 2023 summit. We were so happy to have you all this year and expanding our knowledge and our growth. We also look forward to having you all join us in our 2024 series. and that will be starting in January with our own Chrissy Stockert. Please stay tuned on our social media outlets for more information on that and when to register. And again, thank you all for joining us today, and thank you for partaking all year long with us. We are so excited to have the launch for 2024 and see you all again soon. Thank you so much, everyone, and have a great rest of your day.
Thank you, everyone. Happy New Year.